moving on to our next session. A very interesting debate. It's probably a debate between a medical oncologist and a radiation oncologist. And to chair the session, we have our medical oncologist, Dr. Amit Dattadwari, sir. So may I request Dr. Prosenjit Chatterjee, sir, to come over and chair the session. So I would request Prosenjit, sir, to introduce our debater for the next session.
Good evening. So, as we know, debate is a very important theme of a academic session, and we have got an interesting topic today. The motion goes, neo-adjuvant chemo-radiotherapy is better than neo-adjuvant chemotherapy in esophageal cancer involving lower third and GE junction. And we have got two distinguished debaters today. Both of them are medical oncologists.
Oh,
Dr. Mohan Hingorani from Leeds Cancer Center, he'll be speaking
so
for
Dr.
the
Mohan
motion.
is a clinical oncologist.
Clinical oncologist, okay. And Dr. Vamshi is my good friend. He'll be speaking against the motion. He's from AIG Hospital, Hyderabad. So I would request Dr. Mohan Hingorani to start the session. It's all over to you, sir.
Yeah, okay, thank you. Can you hear me, yeah? Can you hear me there?
Yeah, we can hear you.
Can.
Okay, good. Can you share my slides, please? Yeah. So thanks, yeah. Thank you for inviting me to give this presentation. So I'm actually going to convince you at the end of my talk that neoadjuvant chemoradiotherapy is superior compared to neoadjuvant chemotherapy in cancers of the lower esophagus and the gastroesophageal junction. So before I start, I just need to let you know I'm a consultant clinical oncologist working in the UK. I have been working for Hull University Teaching Hospital NHS Trust and have worked for Leeds as well before, but currently I'm employed by Hull University Teaching Hospital NHS Trust. You got the logo at the top and you got the image of our center as well there. So next slide, please. So what's the evidence for the neoadjuvant chemotherapy or chemoradiotherapy? I think you need to summarize that to have a bit of understanding as to which one is superior, if at all. So this is the slide which is actually taken from the ESMO guidelines for management of esophageal cancer. And what this shows is that they recommend that patients with esophageal cancer who are potentially curable should be staged with the US and the PET scan. So I guess the PET scan is important to exclude any possible distant metastases, and endoscopic ultrasound is important to for local staging of the tumor. And then if you look at the algorithm, you can see for squamous cell cancer, there's no controversy really, because the two options are either you give them definitive chemoradiotherapy or you give them neoadjuvant chemoradiotherapy followed by surgery. That's based on the cross data. However, for adenocarcinomas, which are prevalent in the lower esophagus and the gastroesophageal junction, it specifies both options, that they could have neoadjuvant FLOT or they could have neoadjuvant chemoradiotherapy. So based on that algorithm, you'd feel that both are accepted standards of care, and it doesn't specify which modality would be appropriate for a particular subgroup of patients. So we're going to look at the data for both chemotherapy and chemoradiotherapy, and then try and see which one is better. So can we, next slide, please. So for the neoadjuvant chemotherapy, we're going to just review the randomized key studies. So next slide, please. Yeah. So the three key randomized studies from the past were the first one was the MRC OYO2 study. So this was a very old study done in 2002. It's a MRC UK study where patients were given 2 cycles of platinum and 5-FU and then went on to have surgery. And it showed a survival benefit at 6 years, a small survival benefit from 17% to 23%, but was statistically significant. And the patients who had chemotherapy had a higher incidence of tumor downstaging and also higher incidence of a pathological complete response. And then it's about 10 years later that we had our own MAGIC study, actually, which was the STO2 study, again, MRC study, which was a pivotal study, where patients were given 3 cycles of neoadjuvant ECX, which was epidurobacin, cisplatin, capecitabine, and then surgery, and then further 3 cycles of ECX after that. But the important thing to highlight is that MAGIC study actually had 75% of them were gastric cancers and only 25% of them were esophageal cancers. It was not a purely esophageal cancer study, but nevertheless, it did show a 5-year survival benefit of 14%, so a huge benefit with a hazard ratio of 0.75. Around the same time, there was a French study as well, which looked at very similar design to the MAGIC study, which had 224 patients with esophageal and stomach cancers, but the distribution was reversed. So unlike the MAGIC, actually, you had 75% esophageal cancers and 25% stomach cancers. And that used actually 2 to 3 cycles of platinum and 5-FU. So they omitted the epirubicin. So there was no epirubicin there, and they used 2 cycles of platinum, 2 to 3 cycles of platinum 5-FU, pre and post-op. So very similar to MAGIC, and showed identical results. So the 5-year survival again for this was 38% for the experimental arm and 24% for the surgery alone arm, with a hazard ratio of 0.7. So basically, we have 3 randomized studies showing a survival benefit for neoadjuvant chemotherapy using mainly platinum 5-FU, although in the MAGIC there was epirubicin as well. But more recently, I think that's been dropped from the treatment protocols where platinum and 5-FU is used. Next slide, please. However, the most pivotal study has been the FLOT study, which was published, which was actually presented at ASCO in 2017, which was comparing the FLOT with the standard of care, which was ECX at that stage. So basically, patients were randomized to either have 3 cycles of preoperative and adjuvant ECX or 4 cycles of pre and post-op FLOT. And and we'll just look at this study a bit more in detail. Next slide, please. Yeah. Your next slide, please. Yeah. So in the FLOT study, as you see, there were 716 patients which were randomized to either FLOT or ECF and ECX. And they were basically patients with either gastroesophageal or esophageal. So basically type 1 or type 2 GOJ cancers or gastric cancers. Next slide, please. That was the regime, which I'm sure we all are familiar with. So it's using docetaxel, oxaliplatin, and 5-FU. Next slide, please. So this is the distribution in FLOT, actually. And as you can see, I think most patients were less than 70 years of age, with only 25% of patients more than 70 years of age. Most patients had an ECOG status of 0 to 1, and there were about 45% stomach cancer patients, but the rest were either type 1 or type 2 GOJ cancers. Next slide, please. So can we see so we can see here that there was a significant survival benefit. The median overall survival was 35 months for ECX and 50 months for FLOT, with a hazard ratio of 0.7, and the 10% survival benefit at 2 years, 3 years, and 5 years. So based on that, FLOT actually became one of the standards of care. And any patient who's probably fit for FLOT has FLOT, and if they're not fit for FLOT, then they either end up having platinum or 5-FU. So based on that, so that's the summary of the neoadjuvant chemotherapy. We now need to look on the chemo-radiotherapy side of things. And next slide, please. Sorry, and this is just to summarize the toxicity from the FLOT study. So as you can see that in the FLOT, actually, there was about nearly about 50% patients had neutropenia, and there was a high incidence of infections as well, and there was about 10% risk of diarrhea. Next slide, please. And there was about the 35% grade 3 toxicity for both arms. So 1 in 3 patients did suffer grade 3 toxicity. Next slide, please. So going on to the chemoradiotherapy side of things. Next slide, please. So this was the pivotal CROSS study, which actually established the standard of care for chemoradiotherapy in esophageal cancer. So this was a study which was done it was a Dutch study with 8 participating Dutch centers, which randomized 368 patients with either esophagus or type 1 or type 2 GOJ cancers to having pre-op chemoradiotherapy followed by surgery. And this used 41.4 grain 23 fractions combined with carboplatin, AUC2, and paclitaxel 50 milligram per meter squared weekly. followed by surgery at about 4 to 6 weeks, and the standard of care at that stage was surgery alone. And the patients were actually had to be locally advanced, so either they had to be T2 or higher, with presence of N1 N plus disease. And it included both squamous cell carcinomas and adenocarcinomas as well. And next slide, please. But apart from the CROSS study, there were other 2 studies as well before CROSS, which had shown a possible survival benefit of chemoradiotherapy. One was the very old study, which was a Welsh study, it was an Irish study published by Welsh et al., which showed that 2 cycles of 5-FU and cisplatin combined with 40 grain 15 fractions did induce a significant improvement in survival. And then there was another CLGB study, which was in 2008, which was actually had to be stopped early, so they could only recruit about 50 patients. But it still showed there was significant survival benefit with chemoradiotherapy, again using 2 cycles of platinum and 5-FU, which induced a median overall survival of 4.5 years with the chemoradiotherapy compared to 1.7 years with the surgery alone. So there were already 2 positive studies before CROSS came on board. So it was not like we did not have any data for chemoradiotherapy. However, most people were reluctant to adopt chemoradiotherapy as standard of care because of concerns regarding postoperative mortality. And that was because there were some studies which were done, which showed there was a higher postoperative mortality, but we have to understand at that time the radiotherapy technology was very old, and we were using, and that has significantly advanced now. So it could be that at that stage there was no optimization of the dose received by the lungs or other things which probably may have contributed to the increased postoperative mortality in that study. However, when the CROSS was, the results from the CROSS study, however, showed that there was no increase in postoperative mortality, and it was very low. It was 4% in both the groups, which was reassuring. Now, looking at the results of the CROSS study, next slide, please. So this is the distribution of the patients. So it's a CROSS study not had very, the other impression is that CROSS study had very early cancers. That's not true, actually. And the other impression is that it mainly has squamous cell carcinomas. That's not true as well. In fact, 75% of patients in the CROSS study had adenocarcinomas. Most cancers were lower esophagus and the GOJ. And about 65% of them had N1 disease. So it also had a substantial proportion of adenocarcinomas and locally advanced disease and node positive disease. So looking at the data from this CROSS, actually, as you can see, the 5-year survival for this whole group was 47% compared with 33%. And for squamous cell carcinomas, it was huge with a hazard ratio of 0.5, but only 25% of patients had squamous cell cancer. But for adenocarcinomas, the hazard ratio was 0.75, but it was still statistically significant. I think there's again this thing that the CROSS study didn't show a significant benefit for adenocarcinomas. That's not true. I know the confidence intervals they'd reached to 0.98 for hazard ratio, but still it was statistically significant. And the 5-year median overall survival was 23 months compared to 27 months. Next slide, please. I think I've just put these side by side. So if you can look at CROSS and FLOT data, you can see that with the CROSS, I think there's a higher incidence of pathological complete response and arm-out resection compared to the FLOT study. I know there were 2 independent studies, and I'm not saying that we can make a like-to-like comparison, but what I'm trying to say is that we do see high incidence of PCRs with chemoradiotherapy and also high incidence of arm-out resections. And if you look at the hazard ratios, they're very similar, 0.75 for both the studies. And the 3-year and 5-year survival is very identical. So basically, they are both very effective therapies, and we can't say one is better over the other, but the advantage which CROSS has over FLOT is the toxicity side of things, because the grade 3 hematological toxicity was only 7% in CROSS, and the hematological toxicity was only 13%. If you compare that with FLOT, then basically you have a grade 3 hematological toxicity. The hematological toxicity was only 25%, but the overall grade 3 toxicity was about 35%. So that's nearly 2.5 or 3 times of what the cross showed. So cross does have a significant benefit in terms of reduced toxicity. However, in the cross, there was one inclusion criteria was tumors had to be less than 8 centimeters. And the other thing we have to say is that although 65% of the patients in the cross had node-positive disease, FLOT had about 80% of node-positive disease. So it is possible if you have a higher incidence of nodal involvement, then FLOT may be better in those patients. But next slide, please. So to summarize, I think both cross and FLOT are extremely effective neoadjuvant therapies. Cross regimen is better tolerated with less significant grade 3 or higher toxicity. In our center and elsewhere in the UK as well, I think cross is often preferred to compare to FLOT if the length of disease allows chemoradiotherapy to be delivered. And the important thing we have to understand is that if for very long length of disease, this is not an option. I think ideally the tumor should be less than 8 centimeters. And we have to be carefully looking at the lung DVHS. And I think we normally look at V20, but if you're giving neoadjuvant chemoradiotherapy, we should be looking at V5 and V10 as well, because the lung doses may determine the postoperative mortality. And the stomach extension should not be less than 3 centimeters. Otherwise, you'll radiate most of the stomach and they won't be able to use the stomach to form the esophageal conduit. And the extent of nodal involvement is probably important as well. If you've got more than N2 disease obvious on the staging, then I guess we may have to probably go for FLOT, because FLOT may be more appropriate with high extent of nodal involvement. Next slide, please. So this is I'll just conclude by our own algorithm. So we use both FLOT and cross, and basically our patients do have an US and PET scan. And then we look at the length of the disease. Actually, if it's less than 8 centimeters, there's limited nodal involvement, less than N1 on US and PET, and there's limited gastric extension with adequate cardiopulmonary function, you probably give them chemoradiotherapy. So we prefer that over FLOT, and that's a group of patients. However, if the length of disease is more than 8 centimeters, there's extensive nodal involvement, where we feel cross may not be the best thing, then we go for FLOT chemotherapy. And if patients can't have either, because there are some patients who are not fit, then we go with the MRCOU2 protocol of giving them 2 cycles of platinum and 5-FU followed by surgery. So all those 3 options are there. So basically, I think that chemoradiotherapy has got the advantage compared to FLOT, compared to chemotherapy, compared to especially to FLOT chemotherapy, the advantage about reduced toxicity. However, it can only be delivered in a specific group of patients. Thank you.
Thank you, Dr. Hingorani. That was an excellent deliberation. You categorized it nicely about the protocols and guidelines followed in your hospital. And now I will request Dr. Vamishi to start firing. Are you there, Dr. Vamishi?
Yes, I'm very much there. Thank you.
Yeah, please start.
Okay, so good afternoon, everyone. My topic is chemotherapy for all in EG cancers. The G junction is what I'll be focusing on. I'm lucky enough to work in a center with a lot of GI work, so we do see these patients quite often. And the next 10 minutes or so, we are running slightly late, so I'll just try and finish it off in 10 minutes. Talk of how chemotherapy is what should be preferred for everybody. Next slide, please. Now, this is where we are. We are looking at the lower G junction. We are not going to go beyond into the stomach. We are not going to talk only exclusively of the esophagus. I will make the concession and accept, yes, most of my data is for the adenoceres. For the squamous, the data for neoadjuvant is really not there for larger centers and larger trials from the Western data. I would talk about a Japanese trial, which did have that subset as well. But by and large, what I'll be focusing on is on the lower GE junction and the adenocarcinomas. Next slide. So why do we give neoadjuvant chemo? Let's be honest about it. We need to downstage the tumor. We would want to treat the micrometastatic disease. And finally, very importantly, we need to improve our overall survival. So let's see what neoadjuvant modalities we have for doing this. Next slide. Again, I'm not going too much into individual trials, but let's first start off with the major trial that actually established the role of chemotherapy. That was the MRC trial. Now, this trial has a lot of criticisms for very valid reasons. Biggest, of course, is that you're comparing chemotherapy versus only surgery. Now, I'm sure my opponent must be hearing a ringing bell, because that was what was done in the cross. You know, you had a trial where you compared surgery versus a neoadjuvant followed by surgery, right? So any criticism of magic has to be tempered with the fact that, well, radiation has done the same thing. So in this study, they used 3 cycles of preoperative ECF and had 74% of gastric tumors. Only 12% were G junction. Okay, point to be noted on that. Next slide. Now, when the results came, the PFS was better, the OS was better. Next slide. The next other trial which we included was the FFCD trial. Now, FFCD had something similar. They used a cisplatin 5. Again, look at the drugs. You had ECF, now you have CF. Again, in this trial, when you look at the number of G junction, this is 62%. So much, much higher percentage of G junction. That's what we are talking about today. Next slide. Now, in this trial as well, when you had the final results, it showed you a benefit with giving preoperative chemotherapy. Now, the absolute benefit in overall survival is 14%. Again, remember these numbers, 24 versus 38, right? 24 versus 38, 14% absolute benefit with chemotherapy. Next slide. So then came the FLOT. Now, FLOT is a only study, one of the only studies, which actually has 2 arms that are perioperative or neo-adjuvant, right? This is the biggest advantage or the biggest benefit that we see with the FLOT study. You have 4 cycles of FLOT versus 3 of ECF. Now remember, 3 ECF is proven to be better than only surgery. So this trial, they actually tried to see what happens between 2 perioperative protocols. Next slide. The results were rather clear that the benefit was better when you looked at FLOT in terms of the R0 dissection rate, 84%, surgery undergone in 94%. Again, if these look familiar, these are because this has been covered by my opponent. He talked about cross and the R0 dissection rate, just almost the same as this. Talked about the surgeries, which is the same as this. Talked about the morbidity. If you look at post-op mortality, which is similar in both the arms. So, perioperative FLOT increases the proportion of patients undergoing surgical resection, increases R0 compared to another preoperative protocol. So, that's the takeaway. Next slide. Now, when you talk of FLOT, the other part which we need to look at is the OS, is the PFS and the OS. In both the cases, it is better than ECF. Now, focus here on the hazard ratios. It's 0.77 with the hazard ratio being significant. Both here it is 0.75, right? Look at the projected 5-year survival rate, 36 and 45% for FLOT. Again, remember, we have had data from my previous speaker who talked about cross 5-year survival, which is still almost the same, 40 to 43%. So you are basically having two trials. I agree, cross-trial comparison is difficult, but both the trials are showing the same kind of high OS over the 5 years. Next slide. The benefit for this is preserved for all comers, and that is where the differences start coming between the trials. FLOT showed benefit for T3, T4, showed benefit for node positive, showed benefit for node negative studies, for node negative patients as well. That is very crucial. Next slide. So what about this preoperative chemoradiation other than cross? Multiple small studies, benefits in PFS, results are generally better for the esophagus, not much for the G junction. Next slide. This is the cross paper where, next slide. So this is the cross where you had 368 patients. Remember, FLOT was 776 patients, including both the arms. Here it's only 368 patients. Here, most of the patients were actually adeno, 75% were adeno. G junction around 20% of patients. Next slide. Now, this is what has not been pointed out by my previous speaker. Look at the subset. Now, you can argue that subsets are something that you don't talk about, but when you are having this kind of number of patients, look at the adenocarcinoma here. 0.732, 0.998. It's almost touching the unity. Just about going close. But then when you look at the adjusted hazard ratio, according to the trial itself, it has now crossed the unity. So your benefit here is not so much. More interestingly, look at what's happening in node positive disease. 0.793, 0.807. So essentially, a node positive disease, which is actually more risky, is where your cross is not showing a benefit. Whereas FLOT showed a benefit in all of these subsets. And again, if you remember my opponent's last slide, their protocol, whenever it's node positive, whenever it's larger in size, let's not go for CTRT, let's go for FLOT. Because essentially, FLOT is the better protocol for such patients. That's an implicit admission in his own algorithm, and that's what I also completely agree. And I thank him for showing that slide because it just proves my point and my point of the debate. Next slide. Finally, next slide. The critic study did not again show any benefit of the CTRT. What about any meta-analysis? Now, meta-analysis have been done. There are multiple. I have shown one. I'm sure there are others which can be shown. By and large, what most neo-adjuvant show, next slide, is that both CTRT and chemo are beneficial. But as a network meta-analysis, probably perioperative FLOT is the one most likely to be effective as a neo-adjuvant treatment. Next slide. So then we come to the neo-edges, something that was conspicuously absent from my previous speaker's study, my previous speaker's slides. Now, neo-edges tried to look at phase 3 cross versus perioperative that was modified MAGIC or FLOT. Very interesting. You have MAGIC, which is inferior to FLOT. And yet, next slide, when you look at the number of patients, most of the patients, actually 80% of the patients actually were from MAGIC, not with FLOT, which is a better regime. Only 27 out of 184 were MAGIC, FLOT protocol. Then look at the overall group, 84% T3, C node 1 was 60%. Now the initial power calculation was based on cross being superior at 10%. Then after first futility analysis, the program was changed to a non-inferiority with a margin of 5%. That's a swing of almost 15% from one side to the other. And even on that, the DSMB had to recommend closure of recruitment because there was no probability of survival. The probability of survival is 56 and 57, hazard ratio 1.02. So that's how the neo-edges played out. So a trial which compared directly FLOT and cross found that there was no benefit, even though the very nicely worded statement says that perioperative chemotherapy, there is no evidence that perioperative chemotherapy is unacceptably inferior to multimodality therapy. So make what of you as it. Multiple negatives in the statement. Essentially, CTRT is not better. Next slide. We, of course, have the Oesophageal data, which we are awaiting. But what we need to remember is that even in Japan, which has a much higher percentage of squamous carcinomas, neo-adjuvant chemo is the standard of care, not CTRT. And the reasons are these. Let's come to where we are. We are in India. Now, this was a small single center study which showed in 50 patients CTRT with 90% squamous patients. The completion rate of chemo is only 50%, and the R0 and overall resection rate is only 64%. Adenocarcinomas were majorly non-responders. Next slide. Coming to TMH data from the Tata Hospital in 2020, they published it, and they showed 268 patients with 97% completion rate of NACT, with 66% completion of adjuvant, with an R0 rate of 93%, with a 5-year OS of 37.6%. Remember, the cross 10-year update has still shown a benefit of overall survival of close to only 14%, absolute numbers. But the total number is only 26%. So again, Indian data also suggests that FLOT is a good protocol. Next slide. So if I have to summarize, this is where I think the future is. We are going to go into perioperative chemo with IO. And once IO comes in, I think there's really no role for doing any radiation at all. Yes, we do have a data which says that after CTRT without pathological response, you can add immuno and improve your survival. So going forward, I think immuno in the preoperative with chemotherapy is the way to be going forward. Next slide. Next slide. So for me, this debate is been settled. It's as I have shown, perioperative chemo is the way to go for all G junction tumors. There's no doubt, just as there's no doubt that this gentleman is for me the greatest batsman of all time. Next slide. Thank you very much.
Thank you, Dr. Vamshi. So I think Dr. Hingorani, you are there. Can you just chip in and give your rebuttal?
Yeah, so I think the whole idea of this was to try and come up with the evidence for both possibilities. And I think, as I say, they both have a role in certain group of patients. I think what we can't ignore is that FLOT chemotherapy is a toxic regime. It has got grade 3 toxicity. Not everybody is suitable for FLOT. And in patients who have limited nodular involvement and limited length of disease, this may be a very toxic regime, maybe an over-treatment. We now have data from the Checkmate study as well. So we are using adjuvant nivolumab post-chemoradiotherapy in patients who have residual disease. So they receive nivolumab for 12 cycles. And that actually showed a significant survival benefit for this group of patients. So there was a criticism about chemoradiotherapy not having optimum systemic treatment, but that's not the case anymore because we have randomized data about giving them adjuvant immunotherapy post if they have residual disease post chemoradiotherapy. And I think the important thing to understand is that if you look at the rates of R0 resection and the pathological complete response rates, I think the cross definitely showed a higher proportion of that, of both of them, which I think are important surrogate markers of overall survival. And the other thing to point out is one of the main other criticisms we have is that cross probably the survival benefit was due to reduction in local recurrence. That's not the case, actually. They published a paper subsequently where they showed that there was a reduction in the incidence of distant metastases as well. So basically, it is actually an effective regime, and it has got the high chance of inducing pathological complete response, high incidence R0 resection, and has also been shown to reduce the risk of distant metastases. And combined with the adjuvant nivolumab, which is now approved, I think it is a very good protocol for a group of patients, as long as you can deliver chemoradiotherapy, because you have to have a certain length of disease and the extension to the stomach has to be limited. Thank you.